Hi, so the next lecture is about GERD, gastroesophageal reflux disease. And if I put it very simply, it's decrease in tone of the LES, that's the lower esophageal sphincter, which is causing reflux of acid from the stomach into the esophagus and obviously causing heartburn or GES. What are the symptoms? What are the symptoms? Well, the symptoms of GEF are simple. You'll have heartburn, okay? Heartburn. You'll have bad taste in your oral cavity. You'll have pharyngitis, laryngitis, okay, pharyngitis, laryngitis. You will also have certain amount of dental caries because of the acid that's reaching your mouth. You'll also have definitely you're going to have asthma because of the acid that could reach into the trachea and obviously causing wheezing, like symptoms, wheezing, which could lead to asthma. Now, if you want to investigate this, how do you want to investigate it? You just do an endoscopy, you see the lining change, okay, or you do a 24-hour monitoring of your pH. You do a 24-hour pH monitoring. You put a tube 5 centimeter distal, 5 centimeter proximal to the GE junction, and you measure the pH regularly. Okay, so that is more cumbersome compared to your endoscopy. So definitely you do an endoscopy. Okay. You can also check the LES relaxation by doing a manometry, but again, that's again a very difficult procedure to do. So I'll just write the transient LES pressure or relaxation. Check for that. If there is relaxation, obviously that shows that there could be GERD. What are the complications of GERD? Let's say there's a GERD, you have first complication, a very important complication asked everywhere, is Barrett esophagus. What is Barrett esophagus? Barrett esophagus is just metaplasia, where the squamous epithelium is replaced to the columnar epithelium, okay, to the columnar epithelium. Okay, so this is Barrett esophagus. It's a pre-malignant condition and can lead to adenocarcinoma of the esophagus, and the hallmark is the presence of goblet cells along with the columnar cells. So you want to look for this also on your endoscopy, correct? Now, sometimes when you're looking out for your endoscopic biopsy, right, you also do a biopsy. Obviously, you check for goblet cells and you do a biopsy, and you take a biopsy from the red velvet like mucosa. The mucosa is red velvety because of the non-stop GERD that's occurring. So when the Barrett or the esophagus is seen, and when the Barrett has a greater than 3 centimeter long segment, okay, that means that the mucosa is abnormal. The abnormal mucosa is visible, because anything 3 centimeter, greater than 3 centimeter, it's easily visible. If the columnar epithelium is greater than 3 centimeter, abdominal mucosa is visible. Abnormal is visible. Okay, so biopsy is easily done. But let's say if there's a short segment, okay, if there's a short segment, okay, less than 3 centimeter, because now we have these endoscopes that are very magnified, yet it's visible, okay, and we do the biopsy very easily. We take the section of the abnormal mucosa and we do a biopsy very easily. But let's say if there is another condition where there's a microscopic Barrett. Okay, if it's a microscopic Barrett esophagus, how do you see? It's not visible. Okay, the mucosa is not visible. So what do? The mucosa is highlighted. How is it highlighted? It's highlighted by chromoendoscopy. Now that is basically putting color or a dye to figure out the epithelium. So there are two dyes that are used. One is the methylene blue and the other is the Lugol iodine. Methylene blue, okay, and the other is the Lugol iodine. Lugol's iodine. Now, Lugol's iodine is going to identify a squamous cell metaplasia or squamous cell epithelium. Okay, so you check it's for squamous epithelium, and the methylene blue is going to check for your goblet cell, okay, and your columnar epithelium. So definitely it's going to stain the adenocarcinoma or the Barrett. So therefore, whichever area is stained by methylene blue, we excise that and we take it for biopsy. Okay, that's done. How do you want to manage your Barrett esophagus? Okay, if you want to manage your Barrett esophagus, if there's only Barrett's, okay, and this is based on a Seattle protocol, okay, that most of the surgeons follow. So if it's only a Barrett esophagus, you do metaplasia. Okay, if there's a metaplasia, you just check Okay, you just do surveillance biopsy for 2 years, and you check if there is any progression in disease. Or if it's a low grade dysplasia, now there's a difference between metaplasia and dysplasia, obviously. I think we all are aware of it. So the low grade, if there's a low grade dysplasia, you can do ablation, APC, or you could do RFA, radio frequency ablation, and argon photocoagulation. Okay, which is better? I think APC is better. Sorry, radio frequency ablation is better, because you do not want to use argon. Argon coagulation uses the argon, and radio frequency ablation has lesser strictures. There are esophageal strictures that could be formed as a complication of ablation. If there's high grade dysplasia, again you want to ablate as the same as low grade dysplasia. But if there's a high grade dysplasia, you want to do 3 month after ablation, you want to do 3-month endoscopy every 3 monthly. Here you just need to do, in a low grade dysplasia, you just need to do a 6-month endoscopy. That's it. Okay, and if it's a cancer, you need to do complete esophagotomy. You want to remove the esophagus completely. Okay. Apart from that, I need to talk also about the management of GERD. And the management of GERD is simple. You just need to do fundoplication. So what are the principles of a fundoplication? So if this is the stomach, you want to make sure that the fundus is sitting on the GERD, that is the gastroesophageal junction, GEJ. Okay, GEJ, and the fundus is hitting on the GEJ, and it's making sure that the acid cannot actually enter from the stomach back into the esophagus. Okay, so what are the principles? You need to make sure that this much, the intra-abdominal, if this is the diaphragm, the intra-abdominal part of the esophagus is minimum 3 centimeters. You make sure that the right crus of the diaphragm is tight. Okay, this part is tight, and you also make sure that you do a fundoplication. Okay, and before doing that, you need to do something called as a shoe sign maneuver. Basically, wrap the fundus around the esophagus. Now this can be a complete, this is a partial fundoscopy, that fundoplication that we have done. Well, there is also a complete fundoplication. The complication is simple. In a complete fundoplication, there is it's so tight enough that there is a gas bloat syndrome. So basically, all the gas that's accumulated, you need to burp, right? So you cannot burp because it's too tight. And secondly, sometimes while doing this fundoplication, what happens is that because we have made because of this defect, or let's say there is increased probably weakening of the diaphragm, and there is increased passage of gas from the peritoneum into the diaphragm or into the thorax. So that's basically pneumothorax that can occur. So escape of gas through the hiatus into the thorax during a laparoscopic fundoplication. So laparoscopy is basically you're using a laparoscope to see the structures that are present in the abdomen. So when you use a laparoscopic device, there could be gas that could enter, definitely. So when this gas escapes from this particular hiatus in the diaphragm, because the diaphragm is a little loose in a GERD, so that can lead to your pneumothorax. Again, that's rare. Another very important procedure that you can do is you could do something called as injection of polymers. So you inject polymers out here at the GEJ junction, that is gastroesophageal junction, and that's going to tighten the entire LES. And when it tightens the LES, it's going to cause decreased GERD. That's one. Also, you could do a very important thing called as Colles gastroplasty. So you staple the upper part of the stomach. So let's say you staple the upper part of the stomach, and you invariably lengthen the esophagus. So if I had to draw it, let's say if this is the esophagus, okay, and it's a short esophagus, okay, and this is the stomach, okay, what you do is that you take a stapler and you staple this part. Okay, so basically you're removing this part of the stomach, the fundus, some part of the fundus, definitely, but you're making sure that there is a connection that's present between, there is a connection. Okay, when you're stapling it, I'm not saying you're removing it. Stapling it means making a blind pouch. Okay, so that means this part is yet present. So you've seen we've invariably lengthened the esophagus. So we said this is now lengthened, but initially, if this was the case, the esophagus was only of this much length. for X and Y centimeters. I think that's about it for GERD and its complication, that is the Barrett esophagus. Thank you.